Right then, 3 o'clock, we should officially begin our show. So, Assalamu alaikum, good afternoon, and welcome to Family. My name is Abdul Rahman Farooqi. If you guys have watched my videos and seen a different live show that I've done over the past few months, you will recognize me, and others who are new to this show and new to our channel, new to our page, and welcome you all to Family. And we have today organized in collaboration with Faculty Pharmacy, University for Women, a special show to be able to help out our undergraduate pharmacy students and our future pharmacists, I would say, who will be passing out soon next month, and to be able to give them some sort of a practice-based understanding of what a pharmacist should be doing as in terms of hospital pharmacists in clinical setting. So what we have here is clinical pharmacists involved in clinical practice in hospital. And this is why today I've invited a guest who works in the NHS hospital, the specialist clinical pharmacist, and alongside me in the same hospital. And thank you very much for Emily and Emily Darragh. She's volunteered her time today to be able to come and help us out and be able to share her pharmacy practice experience with pharmacy students in Pakistan, and especially Jinnah University for Women Faculty of Pharmacy students. And thank you very much for joining today and staying live. So I'll just tell briefly about Emily Darragh. She's a specialist clinical pharmacist. He's also called a senior clinical pharmacist in the NHS setting. So when you do your pre-reg as a pharmacist in the United Kingdom, you register yourself as a pharmacist. Once you register as a pharmacist, then when you apply for hospital-based jobs, then you are recruited as a clinical pharmacist. And upon doing all the necessary rotations, and also the clinical diploma, you can qualify for a specialist clinical pharmacist if the job, or if there's any funding available for in that same NHS hospital. So I would take Emily live on our show. So 1 second. Hello, Emily. Welcome to our show. My name is Abdur, and I would like you to introduce yourself. I've done some bits, but people would like to hear from you as well.
Worked in the NHS now for about 1.5 years. And yeah, I'm a specialist clinical pharmacist in the hospital with a variety of different rotations, different roles. So hopefully we can discuss some of them with you today.
Brilliant. Excellent. So before and without delaying any further, what we will do is we'll start with asking questions, because I'll just explain the format of show first. So what I plan to do is we'll ask some questions and answers, and as we go along, we'll have a nice, valuable conversation where our families and the family members will be able to benefit from our conversation in terms of the thing that we share about the role of clinical pharmacists and how we're involved in clinical setting, working with the doctors on the board and stuff. And alongside that, obviously, we would have a Q&A session as well, which is a question and answer session. So the members who are watching this show will be able to ask questions from ourselves, and you guys can leave comments in the comment section, and I'll see the comments. And once we finish what we're doing, and then we'll respond to a question one by one. So we formally begin our show. So Emily, tell us about what is the clinical pharmacist and how they're involved in clinical setting in hospital here in United Kingdom.
No worries. So how we work as a clinical pharmacist in the United Kingdom in the NHS hospitals is we work very closely with a lot of our different colleagues from the healthcare setting. So we're known as what's called a multidisciplinary team. So we have quite good communication with nurses, with doctors, with dietitians, physiotherapists. We're part of this big extended team. And in specifically, our role is more looking at the medication, obviously, as you're well aware. So we're there to give advice to nurses on how to administer medication. We're there to advise doctors on doses, advise doctors on dose reductions, any interactions, and just kind of, especially with a lot of the doctors that come into hospitals, are our doctors that just left the university within the past year. So they're quite new doctors, so they do need a little bit of help sometimes from pharmacists that can help them. So communication is a big key within our job role. Within that, we also have rotations. So we can rotate between different medical wards, different surgical wards. We can also do things like chemotherapy. We can do critical care. So we do a range of different rotations, and the rotations are really good because they allow you to understand the different parts of medicine, really. So critical care is a very complex one, which a lot of people struggle to get their hands on. But once you get there, it's just a joy to be able to learn new things. There's obviously lots of different types of medical wards, from cardiology to respiratory to your care of the elderly. So it's something that allows you to build your confidence, to build your knowledge, and you can take that forward into new roles. So yeah, I think that's it for that part.
Brilliant. You've explained it very nicely and very, I would say, in a term that covers basically all aspects of pharmacy practice. So I will just try to add, I see the definition of clinical pharmacist as a pharmacist in the middle, and one side is the doctor, the other side is a nurse. So being pharmacists, our job is to make sure that what the doctors do, diagnosis. So if they diagnose, it's our job to make sure they prescribe safe. And in terms of nurses and their role is to administer the medication. So our role more specifically go around medicines area. So to make sure that nurses are administering medication safe and doctors are prescribing medication safe. So, it's exactly the same what you mentioned about being involved in training of foundation, one foundation to doctors. They're new to the hospital. They need to know what to do in terms of prescribing, where a renal impairment patient, if it's a pediatric patient, a breastfeeding mother, lactation advice, or hepatic impairment, or anything really, chemotherapy. So tell us more about rotations. You mentioned rotation, the pharmacists are involved in rotation form, being clinical pharmacists, they rotate different areas. So obviously there are a lot of rotations in this very, very short term, and the time that you have, it's very difficult to discuss each and everything. But just an overview quick about like surgical rotation, or I believe you've done chemo rotation as well, and acute medicine. So what is the difference that you see? The pharmacists need to be trained to be able to make themselves ready for these rotations. If they're asked to, for example, when in surgery, you're asked to go to AAU, acute admissions unit. So you go. So what things you need to consider?
Okay, so there is actually differences between the different rotations that you have. So what I'll say with medicine first, so you tend to have your rotations on a 3-month basis. So if you think about it, it's not a lot of time to kind of get your grip onto everything that ideally you should know. And by the time you do, you're pretty much onto your next rotation. But in regards to medicine, what I would say with medicine is it can be a little bit complicated, because with medicine, we can have lots of different issues going on, and we can have complex patients. Whereas compared to, let's say, your surgical rotation, obviously everything that comes through a surgical rotation or the surgical wards is going to be something that's planned. So we have elective planned surgeries. So you're going to see things like pain relief is going to be given, laxatives will be given, and obviously things to stop any clots happening. So your DVT prophylaxis. So they're quite regular in surgery, whereas you may be in medicine, you would see obviously the DVT prophylaxis, but you might not necessarily see such an emphasis on pain relief as such, because that is more based in a surgical rotation. And then taken on from that, you've got your critical care, as I mentioned earlier, is quite a complex one. So this is where patients will have multiple organ failures potentially, and there's a lot that you need to look at. So I'm not quite going to go into that one as much. And then chemotherapy rotation, so that's one I'm currently in at the moment. So that's where we just look at what we call our day case patients. So they come into the ward, they have their chemotherapy, whether that's IV, whether that's oral, and I look at their blood results and see if they're actually able to have that treatment, because sometimes if their white cells are low or their neutrophil levels are low, then they can be what we call contraindicated to have their treatment, because it would make them more ill. So obviously we're trying to reduce the amount of people that are coming into hospital, so we don't want them doing that. But yes, so I order the chemotherapy and authorize it to go ahead. And within that rotation, you will sometimes get, again, calls from the nurses, because their job is to administer. So if a patient came in and they'd lost weight or gained weight, they would tend to ring me, because a lot of chemotherapy medication is based on weight, and we will double check to make sure that it's still safe to proceed before they actually give it while the patient is waiting in the unit. But yes, that's my current rotation. But that was an overview of very quick overview of.
Well, that's very good. Thank you very much, Emily, for that. Tell us about. We'll come back to rotations again and see how it's different to what our target is in terms of when you provide delivery of service. For example, I will just add to what you've added, obviously, or discussed. In medicine, like our targets are different in terms of if this is the admission ward, then we would focus more on medicine's reconciliation and making sure all these patients who want to stay in the ward and going to longer term a medical ward, for example, elderly ward, and they've done the assessment and they think that this patient will require further assessment or further stay in hospital, they go to long-term wards. And this is where we need to make sure that what medication they're prescribed is all correctly prescribed, and obviously the patient history has been taken, and basically everything has been put on nicely, that we don't make sure that patients taking what they're supposed to take. And in terms of surgical ward, just to add, viewers, we also ensure that if the patient had a surgery, just recent surgery, to see if we are giving any medication acutely or chronically to continue or not, matching the suitability of if there's a bleeding risk, if there any other risk that's associated after or before the surgery. So these sort of things we have to discuss with the doctors and do the analysis of what drugs is causing what and whether or not, although we're not adding something new to what they're existingly already taking before admission, but we'd have to, before or after surgery, do the analysis whether or not this patient will be continuing on their regular medication for some time or not. So these sort of things. Tell us about on-call experience. Recently, we were very, very overwhelmed with the on-call experience because of the demand of the hospitals. And we were, just to let you know, on-call is when the operational hours of pharmacy are over. For example, if our pharmacy department is open between 9 to 5, this is where pharmacists on the ward and technicians on the ward, and in hospital pharmacy, we're providing service. So basically, we are operating during those hours. So after those hours, if the hospital needs something urgently, and they don't have in their regular cupboard, they have in the ward, that they have most items that they use on a regular basis as a ward stock. So if they need something other than ward stock, they will need to call the switchboard, and the switchboard will also put them through to whoever the on-call pharmacist on the rota that day. So, and it can be 2 o'clock in the morning, can be midnight, it can be 5 o'clock in the morning. How is, Emily, your experience of on-call since you have joined the hospital and worked out? Tell us and share your experiences, and possibly give examples if you can.
Yeah, of course. So on-call, as you've said, recently has been quite demanding with the COVID situation, obviously the high demand in the hospitals. But my experience from when I first started doing on-calls over a year ago, so when we look at doing on-calls, we have certain what we call like pressure, I call them like pressure indicators of to how full the hospital is. They're called OPAL levels, and you can have 1 to 4. So when it's OPAL 1 and 2, it's quite relaxed. It's not too bad. 3 and 4 is when we're in higher pressure and higher demand. So when I first started, we was a lot about OPAL 2 level. So at this point, as a pharmacist, we're not allowed to come in for discharges, and there is certain criteria that we can and can't do as part of this service. So we look at that. Obviously, recently with OPAL 4, because of the situation with lacking beds, we do come in for discharges. We also, as you said, provide advice as to where a ward could find some medication. So each ward has their own different ward stock. So one ward may stock something that another ward needs, but they don't know that they stock it. So when they ring us and ask for it, we can advise them on where to find it. We also can, in my hospital, we have what's called a robot. So I can dispense medication from home via my laptop, and it'll come out from the robot, and the nurse in charge of the hospital that day can go and pick it up and take it to the ward where it's required. We're also there as another medicines information service. So if a doctor rung up and was worried about a dose he was given a patient for either a renal failure, liver issue, any interactions with their current medical conditions, they can ring us and we can give them advice. So we've had some recently where we had trouble getting hold of phosphate. So we had phosphate polyfuses, and we really struggled getting hold of it. And obviously this can be quite an important medication when we're trying to correct someone's phosphate level. We had the same issue with sodium bicarbonate. So this is even more of an issue, as you may be aware, with diabetic ketoacidosis. So someone's bicarbonate levels can go quite low, and we need to bring them back to normal. And when we didn't have access to these, it could be quite deadly. So I had to go in and administer it to the ward that was required. Right. But I also put some stock into our emergency cupboard, so that they didn't go without any more, and so the emergency wasn't kind of being left. It can be treated quite quickly. I've had calls about from changing people's Parkinson's medication from something that is usually taken orally to a patch.
Right.
So I've had that before.
Hours.
Say that again, sorry?
I was in out of hours, like at night.
Yeah, so that.
Yeah.
Yeah, so that was an early morning call when a patient had struggled to swallow and had missed about 3 of his doses now. And they was getting worried because his Parkinson's was starting to flare up. He was getting more shakes. Mm-hmm. So they wanted it switching to patch. So they rung me, and obviously I advised on what the equivalent dose would be. Right. But yeah, on calls, you can have some very good nights and you can have some very busy nights. So you can't go into on call thinking it's going to be easy because it's Opal 2, for example. You can have your busiest nights when it's Opal 2 than when it's Opal 4. It's
just very unpredictable. You can't tell.
Yes.
Sometimes it's just the easy query, piece of cake. You just ring the phone, said you sorted, and sometimes you have to attend the hospital to do this.
Yeah. And
obviously, it also affects you. It's like having work and what do you call it? The life balance. You need to balance. And then once you're on call, it's very difficult to be able to manage this sort of balance, isn't it? Yeah, it is.
It can be, because especially when you're working from home, obviously you've just come home from working all day, you're just about to sit down and have some dinner, and then the phone rings. So that can happen. You can be called back in. Unfortunately, well, not unfortunately, it is part of our role and it's what we sign up for. We put our patients first, so we need to make sure that we are available for them, that we're there quite quickly if needed. And yeah, on call is fun.
Brilliant. Right. It looks like I have tried to share this video to the group, but it looks like I'm actually live on my own profile. So I'll try and share it in a few groups to see we're supposed to be in family group. And I'm getting messages that actually it wasn't shared in family group. So I'll try and do it, and apologize to the family members. We're probably waiting for me over there, but then obviously somebody would be able to see this. Right, 1 second. Sorry.
Okay.
Right. Okay. Right. So moving on to the service on the ward, for example, if you're doing medicine reconciliation, and technicians are there in the wards to support us. So, what in terms of jobs, like how would you prioritize your work on a day-to-day basis? Because you come to the ward, you have patients going home, you have new admissions, and you have somebody working on critical medications. So, I mean, on a day-to-day basis, especially from pharmacists like yourself, how do you manage your workflow, and what are the things that you see that you will prioritize most, and why?
Okay, so my first key point, especially with working on the wards, is make sure you have a really open, good communication with your technicians. Because technicians will pick up bits, because they're the ones that will actually undertake the medicines reconciliation, and they're the ones that will potentially pick up when patients' medications are being missed. So what I do when I go to a ward is I'll speak to my technician, see what she has to hand over to me, see what's obviously urgent from that list. I'll then speak to the nurse in charge on the ward, ask if there's any discharges, ask if there's any patients that they're worried about in regards to their medications that they want me to see, or any medications that they specifically need ordering. So then once I've gathered all the information that I require, I would prioritize discharges first, especially how we are currently, because we're very short on beds. So I would sort the discharges out first. And so that means ordering the medication to take home, making sure that all the medication they was on prior to admission had a reason if it wasn't prescribed, or get it re-prescribed for them to go home with. I would then prioritize any of the new patients. So part of our service is we need to have reviewed a patient within 48 hours of them arriving into hospital. So I would then look at all these new patients, check their medicines reconciliation. Yeah. So what that means is I would look at the medications they was already on. If they still match, obviously if they're prescribed correctly. If they don't, is there a reason? So if they come in with kidney issues and that's why they need to be reduced or stopped. Yeah. If that's the case, has it been documented? And then I would go, once I've done all my newly admitted patients and got everything sorted with the doctors, so I can communicate with them about why medications I believe should be stopped because of what they've been admitted with. So if patients have been admitted with AKI, you would look at obviously stopping some of the medications such as metformin. You would consider stopping ACE inhibitors, anything that can prolong and make the issue worse, like diuretics would be another one. So once I've had this discussion with the doctor and we've documented and we've gone through and sorted out the new patients, we then go on to the patients that had an existing issue that I wanted to come back to. So in our hospital, we have like colour codes. So we have a red where they need a med rec. An amber is that they've been med rec'd, but they haven't been checked by a pharmacist. Right. We have a blue or a purple, and that means that there's an outstanding issue. And then green means that it's all been checked, all fine by a clinical pharmacist. So I will go to the kind of the purpley blue one next, see which patient had issues and find out through the notes, through the documentation of my colleagues, what the issue was. And again, if it requires discussion with a doctor, try and get the discussion with the doctor underway and get the issue sorted. And obviously I will then at the end of my, once I've sorted out these issues at the end, I'll go and just have what we call a chart check of all the green patients, all the ones that didn't have any issues, but they may have been prescribed something new between yesterday and today that I just need to double check doesn't interact with the medications they was already on. So that's how I would prioritize it on a day-to-day basis.
Brilliant. So things like, for example, it doesn't go your way or we as pharmacists go. For example, if one of the consultants is prescribing an antibiotic, that obviously is not as per the formulary. And guidelines doesn't say that you can give that. If it's a dose-related query, if it's like a combination they're using, it's not appropriate for the diagnosis indication that was made. What is the course of action? Would you share some details of if you would document it and if there's something happen that may have caused patient harm? So would you report it and the system use Datex or Ulysses, and how would pharmacists be involved in reporting these incidents and what would happen?
Okay, so to start with, if they had prescribed something off formulary, there is certain ways that we can look into that. So there's sometimes reasons why in regards that they'll contact the microbiologist. So if there's grown certain cultures in their bloods or in any swabs they've had taken, a microbiologist will advise on a specific antibiotic because it's sensitive to what they've grown. So sometimes that's the reason why they would go off formulary. And for this to happen, we need it to be documented. So if it was to be prescribed and I couldn't see a reason that they prescribed it, I would actually go up to the doctor, ask him what was being treated, why they chose the antibiotic. If they didn't have a reason for it, I would obviously try and say, well, it's non-formulary, it's not the first line we're using this hospital to treat this patient. We need to look at using these alternative antibiotics first, and hopefully try and get it changed if possible. If a patient was given an antibiotic, let's say that they was allergic to, or if they came to some harm, what we have to do in our hospital is what's known as a Datex. So it's an incident reporting system. So there's lots of questions that go through there as to what medication it was, if the patient came to any harm. You calculate the harm that they suffered, or the harm that could have happened. So we then put this all onto a system, and some people higher up in our pharmacy department, or the people that are given these job roles, will look into it a little bit more. They can investigate it. So that'll be speaking to myself, speaking to the doctor, speaking to the nurse, and potentially speaking to the patient if they feel that that's necessary. And it will all get investigated, and a new course, if needed, a new course of action will be underway so that it reduces that risk in future from happening. So we do a lot of risk reduction as well in hospital. So that's why we have so many people check medication, because each time you've got another person checking a medication, it's more chance that you can pick up a mistake. So a doctor could prescribe something, he might not notice his error, a pharmacist could come and look at it and they might not notice their error, and it may be the nurse that's picked up on it when they come to administer it that there's an error there. So we do also do risk reductions, and one way of doing this is going back and learning from our mistakes, really.
Oh, that's brilliant. So you mentioned about the role of a clinical pharmacist in hospital setting, what is it that we do generally, what is expected from our role, and also mentioned about rotation plans, also mentioned what you being involved in the clinical setting when we are down as a on-call pharmacist. Late pharmacists, when we're required to stay late, if we need to finish the hospital, whichever ward the work can come in, obviously we do extra hours, we extend the operational hours. Obviously, most people don't stay late on a regular basis. So, and then we've got, you mentioned about the Datex incident. Tell us more about education and training in terms of how pharmacists are involved in education and training of pharmacy students, whether they're technicians or pharmacy undergraduate students, registration pharmacists, and junior pharmacists, or recently qualified or recently started pharmacists, junior doctors, when they start prescribe and become doctors and come to the board. And obviously, I've met a few doctors on the first day. I remember a few year session. So he was prescribing something, but he was so nervous. And he said, I've never prescribed it, and that's why I'm so nervous. So he was like, you're actually witnessing me prescribing drug for the very first time in my life. So, it was quite shocking for me to understand, and I was pretty chilled out, and I was just telling him about this. And he was like, thinking, what do I do? And the trust that the junior doctors do have on us, it's so much you think you're valuable as pharmacists, the team you're contributing, because they're like, okay, you know what you're doing, right? What do you want me to do? Prescribe this. Okay, what route? So sometimes I feel like we're actually giving them dictation on prescribing, isn't it? The prophylaxis or the regular medication, and we say, if check the blood, don't worry about it, just prescribe it regular. Not we can prescribe one of those things and you feel like, you know what, you should have, obviously, if you're a prescriber, you can prescribe it yourself. So how do you find, sorry, the question is too long now. How do you find or getting involved in training? For example, currently, you're also being involved in training one of your colleagues as well on chemo. So how does that work? And, share the feeling with ourselves.
Okay, so I'll start kind of from the bottom in regards to, so we have summer students that will come to us as summer placements for pharmacists that are still at university. So we need to look at showing them what we do on a day-to-day basis. So in the dispensary, we can take them to the wards as well, so they can see what we do on a ward basis. And it's just more the student placement is more to help them understand the role in regards to the hospital, more than necessarily teaching them anything at the moment. So the teaching aspect comes into it more when they're pre-registration pharmacists and they're with us for a year. So we will teach them about medicines reconciliations, we'll teach them medicines management, things like this, and how to probably better prioritize their job and to understand what is expected of them when they wish to become a pharmacist. So we can go to wards with them, show them what we do, see if they want any feedback, ask them some questions on what they think we should do. So kind of not put them on the spot as such, but give them a little bit of a challenge to see how they would react. We obviously have new pharmacists that come to us that are the lower bands. So I don't know if Abdul's explained, we have different band systems in the hospital.
I think if you can mention that, that'd be great.
Yeah, of course. So when you're a pre-registration pharmacist, you come in as what's called a band 5. As a clinical pharmacist, we're a band 6. A band 7 is what I am at the moment, a specialist clinical pharmacist. And then we have the band 8s, where are the advanced clinical pharmacists. And within 8s, there's different structures for A, B, C, and D. So I'm not going to go into that. But there is a bit of a structure in our hospital. So when band 6s, for example, would come in, they would look at me as someone who would ideally be teaching them the role. So this can mean that I'll need to show them where to access all the information they need, where to find specific staff members if they need to be, because not always are the staff members you need on the wards. Where to find all their training. So when we first started in the hospital, we had to undertake what's called mandatory training. So these are different aspects that we need to have so that we can do our role safely. So this is things like infection control, antibiotic resistance. We do lots of different mandatory trainings, and we have to keep these updated as well on a year-to-year basis. So we would make sure that the new pharmacists coming in can do that. We would take them to wards with us so we can show them our ways of doing medicines reconciliation. They can see how we communicate with our other staff members, and we can give them information on how they can actually proceed, climb the ladder, I guess, in their job, because there is certain things we have to do so that we can gain a higher band. And then in regards to the junior doctors, so at the moment, I also have a junior doctor that I see probably every other week. So what I do for them is they bring me prescriptions, and I have to double check what they've done on their prescription is correct legally, it's correct in regards to how they've prescribed it, their dose, etc. And we will sit and discuss this and say, right, well, let's say this patient, her kidney function dropped to below 30. What would I expect to see you do? Yeah. And they'd explain it. I'd also take this doctor around into wards so they can again understand my role. So as much as I'm taking pharmacists on the onto the wards to understand the role, I'm also taking doctors. Yeah. So to allow a doctor to better understand my role will help them in future to know what I can actually provide them, what I can help them with.
Right.
And
yeah.
As I was saying, you're correct. I have one of my colleagues as well that I'm training on chemotherapy. So we're doing a lot of training, and in our GPHC standards, one of it is to be a leader and be a trainer, be a teacher. So it's part of our job.
Right. So yeah, that's fine. No, that's brilliant. Thank you very much. And then also, this is what happens is, regardless of what band you are, sometimes the requirement is so overwhelming that it's actually coming up. Like, for example, if the ward cover is needed, and we are short in terms of pharmacist numbers, then everybody will jump in and I want to help out on the ward cover and to be able to get the thing that we are supposed to provide, or we call it a clinical service. So we all participate in clinical service and provision. And so that's like being a pharmacist. That's our like main job. And then we have band 6, band 7, band 8. They're like, a job is not different, but there are some additional responsibilities that are added. And as you progress, you develop yourself in terms of what Emily you mentioned about education and training, and then you become band 8A, and you become a tutor for pre-regs, diploma students. Also, you get involved in reviewing policies, reviewing PGDs, and obviously being part of what you are in advanced clinical pharmacy specialist area. So you actually develop yourself in terms of clinical knowledge and be able to contribute in this segment. And obviously, if you're working in a teaching hospital, then you get involved with a lot of research associated with in those specialties as well, with publications and stuff like that. So, and also reviewing as well. Like if you're a senior pharmacist, then you get to review the training pattern that we provide, and you work alongside the education and training pharmacists and the other specialty pharmacists to be able to deliver service. So yeah, anything else you would like to share today, Emily?
Yeah. So for me, one of the main reasons I actually got into the NHS hospital was because of the education that they can provide you in regards to going up the band isn't the right word I'm looking for, but progressing is the word I'm looking for, progressing in your role. So I'm actually currently doing a clinical diploma. So this allows me to go to university once a month, and I can undertake different clinical aspects, like look at it in more detail, and it improves me better as a person to communicate. It improves my clinical knowledge. And there's not only just the clinical diploma you can do, there's so many different courses and different things that you can learn in an NHS hospital, and they never say no, because they always want new people to learn new things. And it's one of the good aspects about being in the NHS, I believe.
Right. Okay. Brilliant. So with the NHS, obviously, I feel very privileged and also very blessed to have worked in a number of hospitals across England, and it feels me really great to be able to contribute, because I'm actually from Pakistan, so, and contributing to them, and to be able to develop a system where somehow I can share my knowledge and experiences, and also my colleagues, if they're volunteer like yourself, and really appreciate your time that you're doing this. Currently where we stand, and I think we're very blessed to have been able to participate in all these things and contribute in patients' healthcare and well-being. And moving forward from here, because the training program has recently changed, I also wanted to share that we are moving towards IFPP, this new program, which is called Interim Foundation Pharmacist Program. And for our new registrants, when they become registered, they automatically will be joining off on IFPP. And the future is all the pharmacists who are enrolled from 2021 onwards, they will automatically become prescribers after 5 years. So if they, when they graduate in 2026. So I think this thing, obviously, it kind of develop ourselves in a way where our clinical involvement is so much and intense, where what we used to do as pharmacists in hospital ages ago, work in hospital pharmacy, we moved from the hospital pharmacy supply section to the clinical role and be able to be involved in clinical decision making alongside multidisciplinary team, as you mentioned earlier, and participate in the decision making process and contribute in such a way where things are not being we're not actually dealt like we are like medication keepers, that we're here to provide medication, so our knowledge is not needed, or our opinion is not required in terms of when two medications are interacting, somebody's inhibiting the effect of the other drugs and stuff like that. So how do you see, Emily, where you are now in 5 or 10 years time, the pharmacy role will be developed in terms of what we need? We are really short in terms of doctors, members, and pharmacists are becoming prescribers, nurses are becoming prescribers. How do you see the roles developing in the NHS as clinical pharmacists? What do you think? I mean, your practice, what do you think? Yeah.
I haven't thought about it a lot, if I'm being honest, but I do think that a lot more of the pharmacists will start to become prescribers, so that we can help in the wards when possible. And currently what's going on actually is you get advanced practitioners, and they're at the minute nurses, but there is some advanced practitioners that are pharmacists in the area. So what these are is they've gone through another course, and it pretty much they're working as a doctor on the ward, so they're prescribing, they're seeing patients, they're diagnosing what's wrong. So some pharmacists as well are going on and doing that training to become advanced practitioners, rather than actually just being clinical pharmacists. So there's that progression as well. So that will allow us, with the lacking doctors that we have, to bridge that gap a little bit by having us as being able to diagnose and prescribe, rather than just being there for information purposes. But then I also believe going forward that we're going to be more involved in a lot more of the clinical decisions. So we're going to be made more into a multidisciplinary team, which involves doctors, nurses, consultants. And I think over these past few years, they've actually seen what we can provide. And I think that's just going to escalate as the years go on.
Yeah.
But
in relation to what
really thought about it.
Yeah, in relation to what you mentioned, someone actually asked a question, and for some reason I can't bring it on the screen. So
that's okay.
A question which is very much relevant to what you've just mentioned. He said, for ensuring safe and effective drug therapy, can pharmacists order lab tests for something they need, which test isn't usually commonly ordered? So,
Right.
go on, I'll let you explain.
Sorry, we don't actually do the drug test ordering, unfortunately. We can advise, we can ask the doctors or the nurses to take a drug test to look at, I don't know, a CRP level, for example, but we can't order them ourselves, unfortunately. But it could be something that can be looked into in the future. I do know, for example, in my role in chemotherapy, if I needed something extra ordering, well, all I need to do is ring the nurse, ask the nurse if they can order an additional test for me, and they just go online and order it. So there's no reason in the future that we couldn't do it, really. But it's not something we do currently.
Yeah, So I would like to answer. You're right about what is clinical pharmacist working here, but I think moving forward, and also as part of my clinical diploma, we had a session. We had a course called clinical investigations and clinical skills. So clinical skills trained us in these setup, obviously, to be able to, when we become an IEP, independent prescribers, we'll be able to do this. When you mentioned about the advanced practitioner pharmacists, so these are the skills the pharmacists will be gaining to develop themselves in diagnosing a medication, diagnosing a disease. So that the role actually not related to medication. For example, if the doctor is checking X-ray for diagnosis purposes, then pharmacists, it would be difficult for pharmacists to read if not trained in reading X-ray, see what the consolidation is. And also, we were okay in terms of interpreting the blood results, but when it comes to doing phlebotomy or taking blood samples, pharmacists train on the ward. But the clinical advanced and the clinical advanced program that's designed for pharmacists, kind of training those gaps where pharmacists become prescriber, and also training in those aspects of doctors where pharmacists haven't been trained, kind of overcoming those requirements to be able to replace doctors on a full-time basis, So you have the knowledge of pharmacy and you have the knowledge of diagnosis, and then the training that will be provided so you can that would assist you in diagnosis. That's it, really. So brilliant. No, that's fine. Anything else? Anybody's got a question? You can leave a question on my profile. And Emily, what you want to add something?
Sorry?
You wanted to add something, no?
No, not that I can think of.
Brilliant. So, okay, that's fine. I would like to share this video with Zainab. She's a tutor. She's a teacher in faculty pharmacy at University of Women, and she is one of the organized actually this session. Unfortunately, for some reason, I couldn't share this video, and I've gone live from my profile. So she's sending me a text to share this, and she's unable to see this video. I was trying to connect it during the session, but obviously this video will be available once the session is done. But due to this reason, we were unable to take a lot of questions because I think most students have missed out on our session. But we will continue. Good points that you mentioned. Very good points. Thank you very much. So, yeah. So actually, we'd like to finish our session, and you want to do your finishing statement, and I'll do it, and then that's.
Yeah, of course. Well, because obviously technology has not worked, if anyone has any questions they want to direct towards me, if you want to ask Abdor, he can pass them on and I can answer them in the best way I can. Yeah. Apologies, I've got a dog that's barking at me. And yeah, so the NHS hospital, the role of the clinical pharmacist is an ever progressing role. So what I'm telling you now, in 2-3 years' time, may be totally different. So we're there as part of a team, whether we're a team in the pharmacy or a team in the hospital, it doesn't make a difference. We're a team of healthcare professionals and we need to put our patients first. And we do that from our knowledge, from training other staff members and from training ourselves, really. So we're continuously developing what we know and making sure that, yeah, what we do is safe for the patient and all the risks are reduced for them, so that they can go home in a timely manner. Excellent.
One thing I wanted to ask you, and I didn't mention, I didn't get a chance to answer this question, is as pharmacists here, what are the resources that we normally use, and any books that you want to suggest, any resources online that you think would be helpful for students or pharmacists qualifying in Pakistan because it's an online world now, so people will be able to access, unless it requires subscription, of course. That's a different story. So would you like to share some your experience, please?
There's not a lot of books necessarily that I use anymore, because like you say, everything is an online world now. Everything is through internet. So like the renal drug database is very good resource. This is for any patients with chronic kidney diseases. It tells you what medications can be reduced, changed. I use obviously the British National Formulary, which will be totally different in Pakistan, but that's what we follow here in the United Kingdom.
The same, to be honest, they follow the same. But thing is, because the National Formulary of Pakistan, it was ages ago. It's never been updated. So what they do is they have different source of information. Actually, when you go to hospital, if it's private or government, you have to ask the prescriber, you need to prescribe something and diagnosis, and what formulary you're using. So they sometimes, I'm using Australian, I'm using American, I'm using British. So so the difference is there's no set way of practice. And this is why pharmacists who are practicing in hospitals, they've got the job, they're working, but I think it's more related to supply of medication than clinical involvement. Some private hospitals are very, very few. They do have practice, but obviously on this scale, on this level, obviously they are nowhere near. So, I mean, and for them to be able to share something similar, that this is how we do it, and it's going to take a few years for them to do it, but obviously sharing our experience with how they do it, so having an understanding of, they can always look up and see, look, this is how I want to do it, you know? But it all requires, I think, collaborative approach, where doctors are following the guidelines and nurses are following the guidelines, and we're all sticking to the same, if it's a trust-related guidelines, or the regional guideline, or a national guidelines, you know? But if no guidelines, then it would be difficult to be able to convey, because I will give you one evidence for, you know, amoxicillin on cellulitis. You will say to me, you know what, I've never seen in my life the amoxicillin is used. You know, you say flucloxacillin. So, you know, this is where sometimes it will be difficult in Pakistan. As a pharmacist, to argue with the doctors, but you know, when they are set sort of standards and everybody is following the same, then obviously things will be streamlined. Yeah. So, what resources you're mentioning apart from BNF? Sorry.
There's lots. There's absolutely. So I think from what you've just said, it's very difficult to be a pharmacist in a hospital in Pakistan. There's a lot of resources we use as well from different countries. So I have also worked in a children's hospital a little bit, and when we work in the children's hospital, some of the formula we use there is an American one as well as the British one. So we have so many different things available to us through the hospital, because we're a specific hospital trust. We have our own guidelines written. We have our own formulary, so we know what to follow, and we can easily find it on our main hub. So if you don't have that, I'm guessing that'll be really difficult. A lot of places, what I will say and what I have learned over the years is, if you do Google something, and I do it with because make sure what evidence you're using is definitely good evidence. It's not something that's just come from someone's word of mouth. You need to make sure that there's evidence backing it up. And it's come from a reputable journal, a reputable source, so that what you're saying is correct. We don't just want to pick up anything off the internet. But our colleagues as well is a massive source of help for us. So sometimes something I might not know, I could go to another colleague and they'll know it like that. And so sometimes experience really helps as well, in regards to finding out sources for us. But you don't know where to look until you need to look, is the problem.
You mentioned about support. So if you're alone and you don't have a support, it's not very motivating. So when you're not, if you have the access to somebody who's able to answer you, as you said, some experience, so that would be a great advantage, you know. So, and also a support in terms of when people are, for example, I still see a lot of doctors come from overseas and they use, I'll quote a recent example. So amoxicillin, flucloxacillin was prescribed for cellulitis, right? So I went to the ward and I asked the doctor, and the one of the F5 1s or 2s they were showing, and they mentioned about specific name of consultant. I wouldn't name him. So they said that's him. So I'm like, well, I don't see amoxicillin flucloxacin combination used,
No.
cellulitis. I've never seen it. I've worked in so many hospitals, but this never seen it. And then looking at the blood test results, the white cell count range normal 107 CRP. So I'm like, that's not like massively, the inflammatory markers not massively raised. So I'm like, yeah, it makes sense, but why would they do that? So I tried to search on the official website where usually I would go and search for evidence, but couldn't find anything. Ended up Googling it. I couldn't find anything. I'm like, you know what? I don't know where that comes from. So I ended up going and asked the nurse, and she goes, oh, he always does that. So that sort of thing, like, I'm being pharmacist, like, what does he do? Like, the doctor say he does, and it's not ideal for a foundation of 1 or 2 doctors as well, because that actually, it sort of sets a norm for someone to be able to prescribe something that's not. So then I saw that consultant walking towards me, and I had a quick chat with him. So, and I said, I was looking for evidence, and he goes, I've always used it, and I find it very helpful. So I'm like, but we've got this, we've got the source for hospital formulary, and it's designed by the microbiologists, and everybody's involved, and they've all thoroughly looked at it. So I think it's best that we continue with flucloxacin. He wasn't quite happy when he looked at me. But I said, I wouldn't feel comfortable clinically verifying amoxicillin for cellulitis when he clearly prescribed flucloxacin. So he looked at me, wasn't happy. He's told them if I once take it off the drug chart. So I mean, that was win-win for me. But then obviously, if it wasn't, then I would have documented it, and I would have, if there was a patient harm or not, obviously depending on if you not needed to text it for incident reporting. So, but then as pharmacists, this is the value. Like they think like there are some outcomes. Something would happen if you don't follow the guidelines, that sort of thing. But if this doesn't happen, then the pharmacists got no power, and we are only a supply service. What we can do is we can recommend, and they say, you know what, just supply me this. You don't know what's happening, because pharmacists don't have blood results, pharmacists don't have the diagnosis, and they're not actually involved in how long they've been given Fluclox IV before they've added the second antibiotic. So it's good to have involvement and the input, and then also the doctors would appreciate that. So I think this sort of culture is set, like also there'll be consequences if they do something on patient harm. They know that the data incident will be coming against their name, and they would have to answer that, So they would know over here there are consequences, and for registration number as well for us as well. We have to be very careful what we advise after carefully looking at these things. So yeah, overall, I think I really like my job when I work on the ward, like, because it tends to bring me in a pool where I can recall things and I just go in my own world, like, play with drugs and open up pages and look at these interactions and contraindications and stuff like that. So yeah, that's it really. So no, thank you, Emily. It's been 57 minutes already, and unfortunately, something happened somehow. And instead of sharing this video on family page, I shared it on my personal Facebook profile. And this is why I couldn't see the comments coming through. But obviously, people have shared it on my profile to the group, and the video will be saved. But the Q&A session that we intended, question answers, they weren't there for us to answer those. So, but obviously, people who have joined us, thank you very much for listening, and thank you very much for watching our show. And Emily, once again, thank you so much for your time on a Saturday that you've given. And I'm sure the Jinnah University for Women will be able to watch this show, a recorded version, and be able to get benefit out from this video. And I hope if they have any questions, they can reach out to yourself, or I'll try and answer them as much as I can, really. So once again, thank you so much. And I think we're finishing now. So,
no problem. Thank you.
Thank you. Thanks very much. Thanks for watching, everyone. Bye. Bye.